So as Neil said, I'm a respiratory and sleep physician. My rooms are based in Bentley, but I also consult here at Cabrini. And my public appointment is at Monash, and so most of what I do is lung cancer, and especially at Monash, I run the lung cancer program and do a lot of bronchoscopy, interventional pulmonology, but then also do general respiratory and sleep. As a part of that, I created this clinic a couple of years ago because of when it will happen to all of us that a CT report will come across our desk and it'll say, oh, there's an incidental finding of a lung lesion, and the radiologist will usually suggest that cancer can't be excluded. And it sort of brings a sudden anxiety to us, it brings certain anxiety to the patient. It's always a difficult situation to deal with. And so I think that even though a large majority of these lesions found on CT will turn out not to be cancer, I think it's important to evaluate them quickly and to either alleviate that anxiety by proving that it's actually not a cancer, or if it is a cancer, diagnosing it quickly, arranging appropriate staging and presentation at a multidisciplinary meeting so that treatment can be initiated quickly. So I set up this clinic through my private room so that if patients are in that situation, we can review them and manage them very quickly. My latest project that has just been something that I've found an interest in is I created my own YouTube channel. So here it is. I've got 122 subscribers now, and it's only been going for a few months. So everyone will have to get on and subscribe to my YouTube channel. I've got lots of videos on there about bronchoscopy, lung cancer, sleep disorders, insomnia, and things. How to save a life, and videos and things like that. And I'll continue to add to it and have a bit of fun. And the reason I started it was because I realised that a lot of the time when I go and do a bronchoscopy for a patient, often they've been referred by another respiratory physician, so I haven't seen them beforehand. And I always felt a little bit uneasy about meeting someone when they're in a hospital gown for the first time, and I'm dressed in blue, usually with a silly scrub hat on, and say to them, you know, introduce myself, now we're about to do this procedure, which I'm going to get consent for. So I created a video of myself just explaining bronchoscopy. So I took a bit of time just to go through it all, explain what to expect, how it's done, and then now I send that out to the patients prior to their test so that when I see them, although we've never met before, I'm a familiar face and they've had time to think about what I'm about to do, and the opportunity for us to meet is more to answer questions and relieve anxiety. And so I put that on YouTube, and then I've just sort of gone from there and created other ones. Anyway, today we're going to talk about lung cancer and lung lesions. And so I'll talk a bit about classification of lung cancer, how lung cancer may present, how to manage that nodule that's found on the CT scan, mediastinal lymphadenopathy, the initial workup of lung cancer with regards to staging, and also a little bit about treatment and some new treatments that are available. So we know what obviously the main risk factors for lung cancer is, and obviously smoking is the main one. We also need to remember though that 1 in 5 people who are diagnosed with lung cancer have actually never smoked. The thing about that is that I think that's, especially in the general public, tends to be not very well recognised, and so smoking and lung cancer have sort of been lumped together, and especially for those patients even those who have smoked, the majority of them are actually ex-smokers, so they're still lumped into this group of like people who may have a self-inflicted disease, which I think is really quite unfair. And I think what we're trying to do is to try and separate that association so that people with lung cancer is not a self-inflicted disease, because a lot of them have never smoked, and the majority of them are actually smokers in the past.
Excuse me. What about the so-called passive smokers?
It's
How
very.
do you qualify that? Smokers and non-smokers?
I think non-smokers. Because
If the husband is smoking all the time and the wife got lung cancer.
Yeah. So in that situation, it's really difficult because it's impossible to quantify the amount of passive smoke someone may have had. You could go from someone who's had a lot of passive smoke, living in a house with someone who's smoking inside, to someone who's lives with the smoker but smokes outside. So we can get a bit of an idea. But I think that there's certainly that will propose a risk. Being especially significant passive smoke is a risk, but it's hard to quantify, and we'll never really know whether that cancer was one that is not due to smoking or is due to smoking. Sometimes through genetic testing we can tell. So if we can identify a genetic mutation, we can say, oh, this is not a smoking-related genetic mutation, but that can be very difficult. So I think we need to accept that as a risk factor, but it's hard to quantify. Asbestos is a risk factor for lung cancer. Obviously mesothelioma and asbestosis are the main problems from asbestos, but asbestos is a risk factor for lung cancer. And if you smoke cigarettes and you've been exposed to asbestos, they have a compounding effect, so the risk is much higher than either one of those risk factors alone. COPD, even COPD independent of smoking, is a risk factor. So if two people have smoked the same amount, one of them has developed COPD but the other one hasn't, the one with COPD is also more likely to develop lung cancer. Pulmonary fibrosis in the same way, HIV, and there are certainly genetic factors, many of which we don't understand. So the classification of lung cancer was always, small cell lung cancer and non-small cell lung cancer, but it's become more complicated. We don't know all that much more about small cell these days, but we know a lot more about non-small cell. And we've got adenocarcinoma and squamous cell carcinoma making up the majority of them, and with large cell carcinoma. And then in adenocarcinoma, we further divide those into those with identifiable genetic mutations in EGFR, ALK, ROS1 or BRAF. And that's important because if we identify one of those mutations, we have treatment that can directly inhibit that mutation and are very effective. And then also immunotherapy is effective in lung cancer, and for squamous cell carcinoma as well as adenocarcinoma, we do a stain called a PD-L1 stain, and if that stain's high, it suggests a good response to immunotherapy. So lung cancer is going to be detected very frequently as an incidental finding, especially with doing CT scanning more frequently. It might be an abdominal scan that picks up a lung base, or it might be a coronary CT which picks up a lung lesion. Otherwise, patients will present obviously with a symptom. And the symptom might be cough, it might be hemoptysis. Although most people with hemoptysis don't have a lung cancer, and the most common cause of hemoptysis is infection. If someone does cough blood, obviously the concern is for a possible lung cancer. They may present with chest pain if it's causing pleural irritation. One of the problems with lung cancer and why we often don't detect it early is because the lung has no sensation, so we don't feel anything in our lung unless it irritates the pleura or it irritates the central bronchi. Could cause shortness of breath, can cause a hoarse voice if it entraps the laryngeal nerve, and it may actually present with metastases. So sometimes patients will present with, say, a brain metastasis and be found to have a lung cancer. So if a patient does have a lung nodule, then this is going to be a very common situation. Probably 1 in 5 people have a lung nodule on a CT scan, so if we CT'd everyone, and the absolute majority of these are going to be benign. So what we need to do though is we need to estimate the risk for malignancy within that nodule, and based on the risk, we'll determine how aggressively we pursue it or what we do about it. And so the risk factors might be patient-related risk factors, so whether they smoke or have smoked in the past, their age, and also history of previous malignancy, and then also, most importantly, the size of the nodule. And so this graph is taken from the NSLT, the National Lung Cancer Screening Trial, where they in America screened tens of thousands of patients with CT scanning, and these patients were at risk for lung cancer, and they looked at all of the nodules, and you can see that the probability of lung cancer increases with nodule size. And so here we've got out to 80 millimetres, so 8 centimetres, and here we've just got out to 2 centimetres. So you can see that at the 1 centimetre mark, the probability for malignancy is less than 5%. So the majority of these lung nodules that we find on CT are going to be 1 centimetre or less. And so immediately we can be reassured that the probability of malignancy is low, so 5% or less. However, as the size increases, obviously the probability of malignancy increases. So you may have heard of the Fleischner Society guidelines. So the Fleischner Society are a group of radiologists that came up with guidelines to tell us how we should manage these patients with nodules less than 1 centimetre. And essentially, if the nodule is less than 1 centimetre, then the majority of the time we're going to just keep this under CT surveillance. So we'll do CT scans at 3, 6, 12, 24 months, depending on and the Fleischner Society criteria will tell us, depending on the risk for cancer and the size of the nodule, how often we do CTs. For instance, if someone is low risk and the nodule is 4 millimetres, we can completely forget about it. If they're at high risk and it's 4 millimetres, we'll do a CT at a year. If they're at intermediate risk and the nodule is, say, 8 millimetres, we'll do a CT in 3 months. and then 9 months. So it's all just dependent upon the risk as to how closely we'll keep an eye on them. If the nodule is more than 10 millimetres, then the risk for lung cancer is getting to that 5% mark, and which is probably, although low, gets to the point where it's unacceptable to have a 5% chance of risk of lung cancer. And so at that stage, we'll tend to do a PET scan. And the PET scan tells us, in addition to the CT, which just shows us what things look like, the PET scan will tell us whether they're metabolically active. So it won't tell us if it's a cancer or not, but it'll just alter the risk or the probability. So if the PET scan shows no metabolic activity, we can tell that either it's not a cancer, or if it is, it's not very aggressive. It's going to be slow growing. And if it's hot, then we know it's highly metabolic. It could still be an infection, could still be not a cancer, but we're going to take it more seriously than if there was no uptake. So if it's hot, we're going to either probably want to biopsy that, or if we can't biopsy it because it's small and in a difficult area of the lung, sometimes we'll just go straight to removing it. If the nodule's more than 20 millimetres, we usually always have to act on that and either try and biopsy it or treat it, remove it. And then also, if there's lymph nodes enlarged in the mediastinum or in the hilum, then that changes things again, because we can quite easily biopsy lymph nodes in the mediastinum and hilum, which I'll show you. And so if there are enlarged lymph nodes, we should really be biopsying the lymph nodes. So just to demonstrate this with a case study, so of a 74-year-old man who'd had a 40-pack year history of smoking and had an incidental finding of a lung nodule. And so here's the CT, and so this is a axial cut with the anterior here and the back here. These are the main bronchi, and so this is the left main bronchi and the right main bronchi going into the right upper lobe, which goes into an anterior and a posterior segment, and here's a lung nodule. And that measures about 15 millimetres, and that looks concerning because it looks spiculated, it's quite round, and I'd be highly suspicious about that. It's in a difficult place to biopsy, especially a CT-guided biopsy would have to come from the outside in, and it has to traverse through lungs, so chance of pneumothorax would be high. This is just showing the mediastinal views, and so we've got the lymph nodes scattered around the airways here, and this lymph node looks normal. This is the subcarinal lymph node station, which looks normal. And so this is the PET scan, and you can see that on this row, high PET activity goes yellow, and on this one it goes black, and you can see that that nodule is highly FDG avid or highly active on the PET, and so we really need to do something about this nodule, biopsy it or remove it. And the problem with traditional bronchoscopy is we put the camera down the airway, and as the airways branch and branch and branch, it gets to a point where the camera can't get any further. And so we can't get to the periphery of the lung lesions, the peripheral lung lesions. So something down here or up here, we're not going to be able to see, so it makes it difficult to biopsy. And so I can tell you that putting a camera down here, I'll see there, but I will certainly not see that. However, with the knowledge of the CT, we can see the posterior segment of the bronchus coming here, and it leads straight to it. So we should be able to biopsy this bronchoscopically. And so what we do is we use this tool called a radial EBUS, and EBUS stands for endobronchial ultrasound, and this is an ultrasound probe that spins in a radial fashion that we can put through the bronchoscope, comes out the end, and we can put it into the lung, and the ultrasound will tell us, are we in normal aerated lung, in which case we're in the normal lung, or are we in a lung nodule which is solid? And once we find the nodule, then we can know exactly where we are to biopsy it. And so this is how it works. So the ultrasound sits within a guide sheath. We put it out, find the tumour. Once we've found the tumour, we take the ultrasound out, leaving the guide sheath in place. So then our forceps and our utensils can go straight back to the right area, and very accurately and safely we know that we're biopsying the right area. How it works. So this is the endobronchial picture. This is the right upper lobe, apical, posterior and anterior segments. We know it's in this segment. There's the ultrasound going out. And we can see the ultrasound image. That's a normal ultrasound image, and there you can see it's going into this solid mass. So the white border is a hyperechoic border, and you can see that that's the ultrasound probe there, and all this is solid. And so we've just pushed past it there, we've gone back into normal lung, and then we've brought the ultrasound back again, and we can see that we're right in it. So we get good depth perception, we know we're in the right airway, so we can quite accurately biopsy that nodule, even though it's very small. And so this is the fluoroscopy picture, so we're taking an X-ray at the same time so we can make sure that the guide sheath is in the right place. And so here's the guide sheath with the metal tip, then that's the ultrasound there. And once we take the ultrasound out, we can replace it with the forceps. We know the forceps are in the right place. And we can biopsy that to prove adenocarcinoma of the lung. And so because the PET scans show that there had been no spread of that, it's early stage 1A, and this was treated with curative surgery.
Can I ask,
Sure.
the invasive procedure at hand, is there any risk with spread?
No, it's a good question, and often patients ask that as well. If you put something in there, are you going to actually spread it? And in some cancers that is the case, and sarcoma is the typical one that you want to avoid biopsying because you can get biopsy, you can spread it. And actually mesothelioma, occasionally that can happen. You can get tract marked metastases, but in lung we don't see that. So here's another case study of a 76-year-old man who's an ex-smoker of 40-pack years once again, presented with cough over 4 months and was found to have a lung mass. And so here's a lung mass now in the posterior area, apical segment of the lower lobe on the left. And once again, this would be easy to biopsy, CT guided. We could put a needle in the back. We don't need to go through the lung at all to get to that. We could also go through the airway because we can see this apical segment airway goes straight into that lesion. However, on the mediastinal views now, we can see there's now an abnormal lymph node. So you can see a lymph node there that's bigger than on that previous one, which measures just over 1 centimetre. So that's concerning for the possibility that this cancer could have spread to that lymph node. And if that's the case, then that completely changes treatment. Because if you were to remove that lung lesion with an operation, it would be not curative if that's a metastasis. So it would be surgery for absolutely no benefit whatsoever. However, if that lymph node is not a metastasis, then this person probably should have surgery because we should always try and treat with curative intent if we can. And so it's vitally important to know whether that lymph node is spread of a cancer or not. And the PET scan helps, it shows that it's avid. However, it still could be sarcoid, could still be infection or inflammatory. So we don't want to say, oh, this looks like it could be spread. We're going to treat you with palliative chemotherapy where there's a possibility that this may not be spread and curative approach could still be possible. So we need to biopsy that lymph node. And previously this was done with mediastinoscopy. Mediastinoscopy is an awful procedure that should never be done any longer, where they cut across the patient's neck in general anaesthetic and they burrow down and pull out these lymph nodes. And it requires admission to hospital, general anaesthetic. So we can do this under conscious sedation with bronchoscopy. And so this is how it's done. And so once again, we've got here the endobronchial picture. This is sitting in the trachea. And from the CT scan, we know that this lymph node is just going to be sitting on the other side of the trachea, just there somewhere. And this is the ultrasound view. And this time the ultrasound actually sits on the tip of the bronchoscope. So we sit down here, we've got a balloon here that sits over the ultrasound. We inflate that just to get good apposition to the airway wall. This is where the needle is going to come out of, that's the sheath of the needle. And we're going to advance the scope on, push it up against the airway wall, and on the ultrasound we should be able to see what's on the other side of the airway. And so here we are, this is the lymph node there, that's the superior vena cava, that was the pulmonary artery just here. So you can see, even though this is in amongst vessels, you can see on the Doppler that's pulmonary artery, but that's lymph node. And from that green dot is where the needle is going to come. So under direct ultrasound guidance, we can very accurately place a needle straight into that lymph node. And so as we advance the needle out, it'll just push the ultrasound picture away. We'll lose the ultrasound picture just for a second, and then you'll see the needle just go straight into the middle of the lymph node. And so even though it's sort of surrounded by vessels, it's only a small lymph node, we can very accurately biopsy that lymph node. And this is the actual smear. You remember clearly from histology, cytology, that these are normal lymphocytes from within the lymph node. But then here and up here are groups of cells that are clearly abnormal, and they're malignant cells because the nuclei all look different, which is, demonstrates that is a malignant lymph node. So this patient has a stage 2A and N3 because the nodal stage is 3 because there's been spread to the mediastinal lymph node. And so that's really important to know because if this person had an operation, then it would not be beneficial. They need to be treated with a combination of chemotherapy and radiation. Here's another one, a 67-year-old lady who was a heavy smoker with COPD, and she presented with increasing cough and had this big lung mass. And this looks certainly very nasty. It's a lot bigger, it's lobulated. The PET scan showed that it's intensely avid, and in the middle you can see there's no PET activity, and that suggests that there's necrotic in the middle. And the PET scan report was that the findings are consistent with a centrally necrotic primary lung malignancy. And so this lady unfortunately was told that she had lung cancer before it was biopsied. And anyway, so we went on to do bronchoscopy once with the radial EBUS, and this turned out to be necrotizing granulomas. And I think it's really important because sometimes the CT or the radiologist or the PET scan reporter will be too confident in their diagnosis of malignancy. And what we always need to remember is that we cannot diagnose a cancer until it's under the microscope. I think it's fine to say that this is very concerning for a cancer. We're concerned that it might be a cancer. There's a good chance that this will be a cancer. But until we've biopsied and it's under the microscope, there's always a possibility that it could be infection or something non-malignant. So I've spoken a bit about mediastinal lymphadenopathy. This is also a really common finding on a CT, and often it's due to sarcoid, especially like this. You can see that there's hilar lymph nodes there on both sides. It's symmetrical. And now that we're able to biopsy these lymph nodes very easily with minimal morbidity, it's very reassuring, and it alleviates the need to do frequent CT scanning to keep the lymph nodes under surveillance. Because the concern is obviously the possibility of an underlying cancer such as lymphoma or metastatic disease from somewhere else.
Have sarcoid patients got a higher predisposition?
No, not for cancer, no. So what do we do about lung cancer? So as a respiratory physician, obviously lung cancer is a multidisciplinary area, and so our role is really in the initial assessment. So someone has been found to have a lesion that could potentially be a cancer, so our role is really to do the initial workup, arrange the investigation, staging and biopsy. We always do lung function tests on patients because often there is underlying lung disease, and if surgery is going to be considered, they need to have a full sort of respiratory workup. And if there is underlying lung disease, we can optimise their lung disease, which might sometimes get patients from not being quite fit enough for surgery, but we might be able to optimise them to improve them, to get them to a point where they might tolerate curative surgery. And all patients really these days, and this is a really strong recommendation from all the cancer councils, and especially from this hospital, Cabrini, and all the public hospitals, is that it's probably the same in all cancers now, that all patients with cancer should really be managed through a multidisciplinary meeting. And we're lucky here, like at Monash and also here at Cabrini, that we have regular weekly lung cancer meetings where we meet with myself, respiratory physicians, and oncologists, radiation oncologists, surgeons, radiologists, pathologists, nuclear medicine, palliative care. A really big, wide group all come together and just talk about patient cases and to ensure that we're offering the best treatment, that nothing's being missed, there's not some other option that hadn't been thought of, and also to discuss, often these cases are not straightforward and they're very complicated, and to be able to discuss them in that sort of forum is really beneficial to the patient. So how do we treat it? So essentially we can treat, I think, any sort of cancer in two different ways. We can either treat it with a curative approach, where the goal of treatment is for cure, and it doesn't mean that we always achieve that, but that's what we're aiming for. Alternatively, we'll treat with palliative approach, where we're not going to get rid of this cancer, but we're going to treat for symptoms and treat for prolonging survival. And that obviously depends upon the stage, which is in lung cancer really the degree of spread. So as I said, if we can get it all out with an operation, then that's great. Then that's the best treatment. But we can also achieve cure with radiation for peripheral lung lesions. And just in the last few years, we've been using stereotactic radiation. And the way stereotactic radiation works for a lung lesion is that instead of beaming radiation through in one direction, through the lung cancer and anything in its path, and to achieve cure in a lung lesion, we would have to do that every day for 4 to 6 weeks. What we can do now is we can do it so that the radiation comes in at all different angles and concentrates right on the lung lesion, and we can cure lung cancers in 2 or 3 treatments. So that makes a really massive change from the previous way of doing radiation. So the thought of having to go 4 or 6 weeks through daily radiation, it can be really difficult for people. And if we can achieve the just as good result, sometimes probably a better result, through 2 or 3 treatments, then that's fantastic. And so it also means that this is also a good alternative to surgery. And so patients who are a bit borderline for surgery, or patients that don't want to have surgery, because there's a lot of, there are complications associated with surgery, provides a really good treatment option for these people. It also emphasises the importance of finding these lesions early if we can, and biopsying them and knowing if they're a cancer. If there is spread to the lymph nodes, but not spread anywhere further, we can use a combination of chemotherapy and radiation, still with curative intent. The cure rate drops off down to sort of about 40%, and the treatment is associated with higher toxicity because there's the chemotherapy, but also these patients do have daily radiation for 4 to 6 weeks. But in someone who's otherwise fit and well, and if they're going to tolerate the treatment and there's a possibility of achieving cure, then that's often a good option. And then if a cure is not possible because of the extent of disease, or if a cure is not possible because of the patient's physical status or comorbidity, then obviously we revert to palliative treatment. And there are certainly new palliative treatments, and a lot of cancers, I think melanoma sort of led the way with like inhibitors of BRAF mutation, and all of the molecular genetics that we now learn about with lots of cancers is certainly, we have that in lung cancer, and I mentioned earlier about EGFR and ALK mutations, and sometimes patients will have these mutations and they'll be treated with an inhibitor and they can do really well for quite a few years. So where the life expectancy for someone with stage 4 lung cancer once it's spread was really sort of 3 months, maybe a year with treatment. Some of these patients are going on to 5 years, which is really quite amazing and a big change. And immunotherapy also is obviously very, very topical, and immunotherapy is effective in some people with lung cancer. The targeted therapies are better. So if there's a genetic mutation, we'll go for that first, but the immunotherapies also provide a good alternative. And I think the thing to remember is that I think people have a stigma about chemotherapy, and that's the losing of the hair and the vomiting and the nausea and just terrible and very hard to tolerate. Where I think that if we have a biopsy and we know more about the actual tumour, then we can potentially offer some of these treatments, which are given as a tablet, with very minimal side effect and quite effective. So rather than for patients to say, I'd never have chemotherapy, I think if they're aware of these advances, then it's useful to know, because it does sort of change the way that we approach it, where previously we might have said, well, if you're not going to have chemotherapy, there's not really much point in biopsying it, because why would you put someone through a procedure if you're not going to act on the result? Where now, because we've got these good treatments with minimal comorbidity, as a matter of fact, I just did my bronchoscopy for the oldest person in the history of what I've ever done, and he was 98. But he was really functioning really well, and like I spoke to him for quite a long time and his family about doing bronchoscopy to find out and what we would act on the result, and it's actually come back as small cell lung cancer. So without treatment, his life expectancy would probably be 2 or 3 months, but with treatment of small cell cancer actually makes people feel better. So I haven't seen him for the results. That's actually this afternoon. But it'll be interesting to see whether they elect for treatment or not, because that's obviously going to be a very difficult decision for him and the family, and for me to help them with. And we also need to remember that I think that it's okay not to treat. We don't have to treat. Just because there's a disease there, we don't have to treat it. And especially in that setting, like for this patient this afternoon, who's 98, if he just doesn't want to have chemotherapy, that's absolutely probably the most appropriate decision. But they don't need to be 98 to choose not to have treatment of the underlying cancer. And I think it's useful to differentiate treatment of the underlying cancer from treatment of the patient, and we can still treat the patient with any sort of symptoms, and we can still look after them and treat them and things, but it just doesn't mean we're treating the underlying cancer. So we can treat their pain, we can treat their cough, we can treat their breathlessness, we can treat all of those other things that are associated with having lung cancer. So in summary, I think lung cancer often presents with non-specific symptoms. So we should think about CT of the chest for those patients at risk. But lung lesions on CT are not a cancer until proven on biopsy, despite what the radiology report might say. We need to remember bronchoscopy and EBUS are really good technologies and really advancing very quickly and provide us with a very good way, a very safe way and quick way to be able to biopsy lesions in the lung and also lymph nodes in the mediastinum. And I think that, from a respiratory point of view, and it's certainly the way that we set up the lung cancer clinics through Cabrini and also at Monash, and all of the hospitals are really now going this way, that the respiratory physician is really sort of the gateway in with the lung lesion to diagnose, stage, manage, and then present at the MDT for then treatment decisions to be made. And patients shouldn't really be undergoing surgery or treatment of lung cancer unless they've gone through that multidisciplinary meeting. And it's useful, I think, to keep in mind that there are lots of new treatments and lots of new things that we can do for these patients that will improve outcomes. So lung cancer, although it's still a devastating disease, and more people die of lung cancer than any other cancer, there are better treatments and things are advancing in better ways that we can help our patients. I think that's yeah.
Few questions. How often do you experience